Imagine a clinician, just standing in an examination room looking at a patient's skin.
Right.
And scattered across the surface are these tiny, non-fading red dots. It's a really subtle visual cue, but in the medical world, it's actually this huge, high-stakes crossroads.
Oh, absolutely. It's a massive decision point.
Right. The clinician has to ask themselves, are these little red dots simply the harmless result of, decades of summer sunshine,
Uh,
just a map of a life well lived outdoors? Or, and this is the scary part, are they the very first blaring alarm bells of a life-threatening, rapidly spreading viral infection?
yeah, and you're looking at exactly the same fundamental presentation there. It's blood outside of a blood vessel.
Right.
But the implications are literal life and death for the patient.
Wow.
So the clinician has to act fast and, well, they really have to get it right.
Okay, let's unpack this because today, for you, our listener, we are looking at a huge stack of clinical guidelines, emergency department protocols, and some really dense dermatology research.
Which is super fascinating stuff, honestly.
It really is. And our mission is to understand how medical professionals visually decode those tiny red dots. In the clinic, they call them petechiae. And to really see what we're talking about today, I want you to imagine a split screen.
Yes. The split screen is the best way to visualize this. So on one side of that screen, visualize a macroscopic view. Think of deeply sun-damaged, paper-thin skin, maybe on the back of an older adult's hand.
Okay, got it.
Then on the other side, zoom all the way in to a microscopic view. You're looking at a vibrant, active capillary bed deep inside a child's body. And that capillary bed is actively under attack by a virus.
So two completely different worlds. But before we could figure out how a doctor distinguishes between those two vastly different scenarios, we need to make sure you understand what these dots actually are. I mean, biologically speaking.
Right, because if you're looking at a red rash, you have to first prove it's not just, a standard allergic reaction or like a patch of eczema.
Exactly.
Right.
Definition is everything here, right?
It is. So petechiae are pinpoint, flat, red, or purple spots. The strict cutoff in the medical literature is that they are less than 2 millimeters in size.
Less than 2 millimeters, so really tiny.
Yeah, microscopic almost. If you see spots larger than 2 millimeters, the clinical term actually shifts. They call that purpura. And if they are massive, say over a centimeter, they're called ecchymoses.
Which is just a fancy word for a bruise, right?
Exactly.
Yeah.
Most of us just know that as a standard bruise.
But regardless of the size, the underlying mechanism is identical. It's a process called extravasation, which is a great word. The blood has quite literally left the pipes and is sitting inside the walls of the house.
That's a great analogy.
Thanks. Yeah, so red blood cells have leaked out of the tiny capillaries and are just completely trapped in the surrounding tissue of the dermis.
And that leads to the first major hurdle for the clinician. They have to confirm that extravasation has actually happened.
Because, a lot of things make the skin turn red.
Exactly. Sunburns, heat, rashes.
Right, and they use a diagnostic tool for this that is brilliantly low-tech. It's clinically called diascopy, but you'll usually hear it referred to as the glass test.
The glass test. It's a classic.
So the clinician takes a clear drinking glass, or maybe like a clear glass microscope slide, and they press it firmly against the red spots on the patient's skin.
And what's fascinating here is how the mechanics of this test are just incredibly elegant. Think about a standard inflammatory rash like a sunburn or contact dermatitis.
I always picture that like a red sponge full of water.
Oh yeah, perfect.
If you press a heavy glass down on that red sponge, you physically squeeze the fluid out of those inflamed, dilated surface vessels. The fluid gets pushed away to the sides, so the skin right under the glass momentarily turns white.
And clinicians call that blanching.
Blanching, right?
If the rash blanches, you instantly know the issue is vascular and inflammatory. The blood is still safely contained inside the vessels. The body has just sent more blood rushing to that specific area because of inflammation.
So the pipes are completely intact.
Exactly. The pipes are fine.
But if you press that glass down on our tiny red dots and the redness doesn't fade at all, that is a non-blanching rash. It's like looking at a red wine stain on a white carpet.
Oh, that's spot on.
You can press down on that carpet stain as hard as you want with a glass, but the color isn't going anywhere. Because the dye is already trapped in the fibers. The blood has leaked completely outside the capillary and is physically trapped in the dermal tissue.
And that test gives the clinician immediate, incredibly high positive predictive value.
Without drawing a single drop of blood.
Right. Without waiting hours for a lab result, the clinician knows for a fact they are dealing with a hemorrhagic lesion. The structural integrity of the vascular system in that tiny area has basically failed.
So the glass test confirms the blood is leaking into the carpet. The immediate next question is, well, why? Why did the container break in the first place?
Which is where things get really interesting.
Yeah, and going back to our split screen, the first major suspect, especially in older adults, is that the container, the skin, and the blood vessels has simply rotted away over time.
Which brings us to a concept in the dermatology sources called dermatoporosis. It's essentially chronic cutaneous insufficiency, and it's heavily tied to conditions like actinic purpura.
Sometimes called senile purpura, right?
Yeah, exactly.
Dermatoporosis, I mean, the dermatologists who coined that term back in 2007 obviously wanted to evoke osteoporosis.
They did, and for very good reason. They wanted to communicate that same sense of slow, structural, just inevitable failure.
Wow.
And the prevalence rates are staggering. The data shows this affects roughly 32 to 37% of individuals between the ages of 60 and 90.
That's a third of all older adults. So if you're wondering what actually happens at a biological level to cause this decay, it's not the result of one terrible sunburn at the beach.
No, no.
It's this slow, cumulative assault. Decades of chronic UV radiation, the natural intrinsic aging process, and often the long-term use of corticosteroids. All these factors gang up to attack a specific cell surface receptor in the skin called CD44.
And that receptor acts like a master switch. When it's functioning properly, CD44 stimulates the proliferation of fresh skin cells and drives what we call the hyaluronosome.
The hyaluronosome.
Yes, you can picture it as the skin's microscopic factory for churning out hyaluronic acid.
And hyaluronic acid is the holy grail in skincare for a reason. I mean, it holds on to water. It's what gives young, healthy skin its volume, its plumpness, and its mechanical resistance to shear forces.
Right, it's the balance.
Yeah, the bounce. When you bump your arm on a door frame, hyaluronic acid and collagen are the shock absorbers.
But when that factory shuts down due to UV damage or just aging, the physical structure of the skin just collapses. Healthy skin typically has a thickness of about 1.4 to 1.5 millimeters.
Okay.
In severe dermatoporosis, that thickness plummets to a paper-thin 0.7 or 0.8 millimeters.
So literally half the thickness. The dermis loses its volume, the collagen fibers degrade, and those tiny little blood vessels lose all their protective cushioning.
They're completely exposed.
Yeah, they become so fragile that just the friction of putting on a tight sweater can tear them open, spilling blood into the tissue. But wait, I have to bring up a huge medical irony here regarding corticosteroids.
Oh, yes. The steroid paradox.
Yes, because I was reading through the source material, and it feels entirely counterintuitive. Dermatologists prescribe topical corticosteroids all the time to treat skin inflammation.
They do, yeah.
If you have a terrible rash, you get a steroid cream. But the literature explicitly lists long-term corticosteroid use as a primary driver of this severe skin atrophy. So why is the cure causing the container to break?
It's one of the great double-edged swords in clinical medicine, really. Corticosteroids are absolute magic at suppressing an overactive immune response.
Right.
They calm the inflammation down rapidly. But the molecular mechanism they use to achieve that comes with a massive toll on the tissue's architecture over time.
So they're essentially trading short-term relief for long-term structural damage.
Correct. The steroids specifically target and inhibit an isotype of that CD44 switch in the skin's primary cells.
Oh, wow.
Yeah, so by turning that switch off, the steroids directly shut down the hyaluronic acid factory. But they do something even worse.
What's worse than that?
They alter gene expression to ramp up the production of specific enzymes that literally dissolve protein. So you cure the itchy rash today, but if you use it for years, you are actively dissolving the skin's structural scaffolding.
That is wild. So knowing that underlying biology, what does a clinician actually look for to confirm that the petechiae they are seeing are the result of this slow dermatoporosis decay?
Well, they hunt for a very specific constellation of visual clues, starting with location. If the decay is driven by the environment, the damage should map to environmental exposure.
Makes sense.
You will almost always see these petechiae confined strictly to sun-exposed areas. So the extensor surfaces of the forearms, meaning the outside of the arms, the backs of the hands, the V of the neck.
Places where the sun has been hammering those microscopic factories for like 60 years. You don't typically see actinic purpura on someone's stomach or upper thighs.
Right, exactly.
And then there's the appearance of the skin itself, which the sources describe as translucent, where the underlying veins and tendons are hyperprominent because all the padding is just gone.
They also look for white pseudoscars, which is a fascinating visual finding.
Oh my gosh, the mechanics of those pseudoscars blew my mind. They look like little starry, white, jagged marks scattered across the thin skin. But they aren't scars from a cut. The epidermis, the very top layer of the skin, was never actually broken.
It's amazing. Think of it like snapping a rubber band while it's inside a thin nylon sleeve.
Okay.
The nylon sleeve, so the top layer of skin, stays perfectly intact.
Mhm.
But the rubber band inside, the dermal collagen, was so weakened and fragile that it fractured and snapped under the tension of everyday movement.
And the white mark left behind is the visual evidence of that internal structural failure.
Exactly.
And if that wasn't vivid enough, the sources mention another clue for chronic vessel leakage called the cayenne pepper sign. You see this often in a variant called Schamberg's purpura.
Yeah, when these highly fragile vessels leak a tiny bit of blood and then heal and then leak again over months and years, the body has to clean up that spilled blood.
Right.
The red blood cells break down, and they leave behind an iron storage complex called hemosiderin.
Which is basically biological rust.
That's a great way to put it.
Yeah, the body fails to clear all that iron away, and it literally rusts under the skin. It permanently stains the tissue with this brownish yellow or rusty red discoloration. It looks exactly like someone sprinkled cayenne pepper on the patient's shins or ankles.
So when the clinician sees the paper-thin, translucent skin on the forearms, the starry white pseudoscars where the collagen snapped, and the rusty cayenne pepper stains, they can be highly confident.
This is atrophy.
Yes. The container slowly rotted away from decades of environmental damage.
But now we need to look at the other side of that split screen. We have to pivot from the 60 years of slow decay to 60 minutes of absolute chaos. What happens when the container isn't slowly rotting, but is being violently blown apart from the inside out?
Yeah, this takes us out of the outpatient dermatology clinic and drops us straight into the pediatric emergency department.
Totally different vibe.
Completely. A child presenting with a high fever and a rapidly spreading petechial rash is arguably one of the most anxiety-inducing scenarios a clinician can face.
Because historically, that presentation just screamed meningococcal disease.
Right. Meningococcal disease is a bacterial infection of the bloodstream that is notoriously ruthless. It can progress from a seemingly mild fever to septic shock and death in a matter of hours.
It's terrifying.
For decades, that was the absolute dread hanging over every emergency room.
But I was reading through the emergency department clinical guidelines from Sheffield Children's Hospital, and they highlight this massive paradigm shift. The actual statistical reality of the ER has changed completely in the last 2 decades.
And if we connect this to the bigger picture, it's one of the greatest yet quietest triumphs of modern public health.
Oh, for sure.
Because of the incredible widespread success of meningococcal vaccines, the incidence of these catastrophic bacterial blood infections has just plummeted.
So when a parent rushes a child into the ER today with a fever and petechiae, the most likely culprit is no longer a deadly bacteria. It's much more likely to be a viral invader. Things like enterovirus, parvovirus B19, dengue fever, or even COVID-19.
The statistics have completely flipped. But the clinician standing at the bedside can't just play the odds.
No, of course not.
They cannot gamble with a child's life by assuming it's a routine virus. They have to actively hunt for visual clues that tell them the nature of the acute internal attack.
And the first clue is how the virus actually causes the blood to leak, because it's completely different from the slow decay of sun damage. A virus circulating in the bloodstream isn't wearing down the hyaluronic acid factory.
No, it's much more direct.
Right. It's actively attacking the endothelial cells. Those are the specialized cells that line the inside of the blood vessels.
The virus hijacked those endothelial cells,
Mhm.
causing massive inflammation. The cells swell, they lose their tight connections to one another, and they physically separate.
Like unzipping.
Exactly. The pipes literally become porous, allowing the red blood cells to spill out.
And because that virus is pumping through the entire circulatory system, the visual pattern of the petechiae is totally different. You don't just see it on the sun-exposed forearms. Infection-driven petechiae are generalized. They are scattered randomly across the torso, the legs, the back.
Speed is the other major red flag here. A rash that is noticeably expanding and popping up in new locations across the body over a matter of an hour or two implies a systemic firestorm. The invader is chewing up the vascular lining everywhere at once.
But the clinical guidelines also teach doctors to look for mechanical clues. Clues that might explain the petechiae without it being a direct viral attack on the blood vessels. I found this part so fascinating.
Oh, the mechanical pressure side of things.
Yes. They specifically tell clinicians to check the SVC distribution.
Right. The SVC is the superior vena cava. It's the massive vein responsible for draining all the deoxygenated blood from the upper half of the body back into the heart.
So the guidelines say to look and see if the red dots are strictly localized above the nipple line, so just on the upper chest, the neck, and the face.
Because if they are, it tells a completely different mechanical story.
Exactly. If a child has a nasty but routine respiratory virus, they might be coughing violently, or they might be vomiting repeatedly.
Think about the intense physical strain of a severe coughing fit. It causes a massive temporary spike in pressure inside the chest cavity.
And that pressure backs up into the superior vena cava, and the tiny, delicate capillaries in the face and neck simply pop under the intense mechanical pressure. The virus isn't chewing through the vessel walls at all. The physical force of the cough just blew the pipes out.
It changes the clinical picture entirely. A child with petechiae, only around their eyes after a coughing fit from a cold, is a drastically different scenario than a child with petechiae erupting all over their abdomen and legs.
Which brings us to the unwell presentation outlined in the guidelines. Because a clinician isn't just looking at the dots, they are looking at the entire human being in front of them to gauge how the body systems are holding up under attack.
They're constantly evaluating tissue perfusion.
Right.
Is the cardiovascular system still effectively delivering oxygenated blood to the furthest reaches of the body? They feel the patient's hands and feet. Are they unusually cold or mottled?
They also test capillary refill time, which, by the way, you can actually try right now. If you squeeze the tip of your finger firmly, the skin turns white as you push the blood out. When you let go, you time how many seconds it takes for that healthy pink color to return.
In a healthy person, it should be almost instantaneous, definitely under 2 seconds.
Right.
But if it takes 3, 4, 5 seconds for the color to return, it means the cardiovascular system is really struggling. The pipes are either leaking too much or the heart is failing to pump effectively.
Add in inappropriate tachycardia, which is a heart rate that is racing way faster than a fever alone would explain, and neurological signs like extreme lethargy or irritability, and the clinician knows the patient is losing the battle against the infection.
So if we bring all of this together, how does a clinician synthesize these clues at the bedside? How do they run the differential diagnosis using just their eyes, their hands, and a drinking glass?
So what does this all mean? It's essentially a rapid-fire visual deduction. First, they do the glass test. They press it against the rash. It doesn't fade. It's non-blanching. Boom, they have confirmed hemorrhage. Blood is in the carpet.
Next, they assess the location and spread. Are the dots confined to the sun-exposed forearms of a 75-year-old? The evidence points toward atrophy. Are they confined to the face of a coughing toddler? The evidence points toward mechanical pressure. But if they are generalized across the trach and spreading rapidly, the alarm bells ring for an active systemic infection.
Then they evaluate the skin architecture itself. They look past the red dots. Is the surrounding skin normal thickness, hydrated, and elastic? Or are they looking at 0.8 millimeter translucent parchment covered in snapped collagen pseudoscars and rusty hemosiderin stains?
The architecture tells them if the container was pre-broken by time.
Exactly. Finally, they scan for severe complications. In extreme cases of dermatoporosis, the skin failure can be so profound that you see a deep dissecting hematoma.
Oh, those are brutal.
It looks like a massively swollen, warm, red lower leg. It mimics a severe skin infection like cellulitis, but it's actually a massive pool of blood tearing through the tissue planes simply because the skin's structural integrity is gone.
And on the infectious side, they're hunting for the ultimate nightmare. Necrotic bullae, also known clinically as purpura fulminans.
Which sounds as bad as it is.
It is. Purpura fulminans is a sign of severe sepsis. It happens when the bacterial or viral infection triggers the body's clotting cascade to go completely haywire.
The blood starts clotting spontaneously inside the vessels, right?
Yes, effectively cutting off the blood supply. The tissue literally starts to die, forming dark, hemorrhagic, blistering lesions. It is a true medical emergency.
The skin is acting as a literal crime scene. The clinician is playing detective, reading the blood spatter to determine the exact nature of the crime. By looking at the location, the color, and the surrounding structural damage, they can figure out if they're looking at a house that slowly rotted away from 60 years of water damage or a house that was violently blown apart from the inside in an hour.
The evidence is all right there on the surface, written in extravasated red blood cells. You just have to know how to decode the pattern.
That's amazing.
It really grounds the practice of medicine in the physical examination, proving that even in an era of multi-million-dollar imaging and genetic sequencing, keen observation is just irreplaceable.
A trained clinician can use a cheap glass and an understanding of starry scars to separate a harmless, inevitable aging spot from a life-threatening emergency. That is incredible. But before we wrap up this deep dive, there was one final, truly mind-bending connection buried in the research on actinic purpura that we just have to talk about.
Oh, yes. We spent a lot of time discussing how UV radiation and aging systematically destroy the collagen in the skin, leading to that paper-thin dermatoporosis.
Right, the loss of collagen.
But the research points out that those specific collagen alterations in the skin are remarkably similar, on a molecular level, to the bone density changes observed in osteoporosis.
Wait, so the decay of the skin's collagen is physically mirroring the decay of the bone's collagen deep inside the body.
Exactly. It suggests a systemic collagen change affecting the whole body simultaneously, which means that as we age, our visible skin isn't just a wrapper holding our organs in.
Mind blown.
Right. That paper-thin, easily bruised skin on the forearm might actually be acting as a transparent external dashboard. It is visually broadcasting the invisible structural decay of the skeleton.
So the next time you look at a simple purple bruise on the back of an older person's hand, you might literally be looking at an indicator of the structural integrity of their bones. That is a profound thought to end on. Thank you for joining us on this deep dive into the hidden language of the skin. Keep questioning, keep observing, and never underestimate the fascinating clues that are hiding in plain sight.